start by thanking three people: Dr. Bandari for the kind invitation to be part of the program, to Dr. Menon, who, without his vision and courage to take on this project, it should be clear, if not now, by the end of this conference, that none of us would be here without the work that he undertook, and for Rajan Padmavidakudi for funding the whole crazy enterprise. I'm going to talk some about the resident and fellow training. What I'm going to say is going to be somewhat redundant since I'm following the talks that Alex Mottri and Khurshid Guru just gave. But I'll have some points I think that bear repeating, and then I think it'll be very interesting to me, and I think probably the other panelists, to see the next part of the program after the discussion, in which we'll hear from some of our colleagues here on how they feel their training could have been better. Because I think we're telling you what we think, but it'll be very interesting to hear what the opinion is about how the training has gone so far. So this robot is it's a powerful tool that allows us to do complex procedures, but it's not some kind of a magic wand. It's not something that you can just point at a problem and it will take care of it. To paraphrase what Dr. Menon said earlier today, the robot doesn't do your operation, the surgeon using the robot does. And it is incumbent on us to really learn how to use this tool well so that we can take good care of our patients. And that's where the training comes in. It's incredibly important. If you think you wouldn't send your 16-year-old son or daughter out in a car for the first time with an hour or two of instruction, they spend months and many long hours trying to learn. Similarly for flying a plane, it just it's much more complex than I think it seems sometimes. As Alex had said, there really is an absence of official standards, either from academic medicine or organized medicine or the government in terms of what training should be. So it's been left to Intuitive Surgical to propose things. The AUA is starting to step up, and as you heard from Alex, the EAU also, in terms of coming up with some guidelines for what should be sufficient training. But it really is ultimately an individual thing, how long it takes for somebody to be trained. But there's still some principles that we can go through. In the U.S., training has evolved. 10 years ago when we started, it was expert open and laparoscopic surgeons who went from being expert to being trainees and trying to learn, and their residents and fellows were acting in a supporting role. That was certainly the case at our institution at Henry Ford. And then as we learned, we began to be able to teach the residents. The residents, I think, and I'm sure, learned some from our struggles as we were learning. Now, as more programs have expert robotic surgeons, the training has really become part of the residency program, and residents now in the States are expecting and expected to graduate with a certain set of robotic surgery skills, whereas as little as 4 or 5 years ago that wasn't the case. And I think in India now that is also sort of playing itself out again, as Dr. Menon also said earlier this morning. Over the next 10 years, he predicted that a similar sort of sea change will happen in India as it's happened in the U.S. and is largely happening in Europe. Most of the training here has been through mentoring by expert surgeons in the U.S. With some short visits. So. To just talk about training, I've had the opportunity to train over 30 residents and fellows, and I've had a number of opportunities to train programs around the country in the U.S. and internationally. And we've really been believers in an intensive training program. The intuitive course that Alex talked about, of a couple-day course with a pig lab, is the bare minimum to get started. That just sort of gets you an understanding of the program, but you really have to spend much more time training and learning, and I'll talk about some of those principles. The first thing, and again Alex emphasized this, is to establish a team, and it's a team of anesthesiologists, surgeons, nurses, and assistants, and you need a dedicated team, one that will keep showing up. It has to be a consistent team. You can't have, to be effective, I think, people coming in and out and learning and forgetting and trying to relearn the steps at all the levels, the nursing and the assistant level in particular. The initial step should be learning the function of the robot, and the dry lab is a useful place for that. This can be practiced over and over again with before a patient comes into the room, so that the team is very efficient at getting things set up. The use of simulators probably less important for the setup of the robot, but going forward there may be a role for that as well. Learning and understanding the procedure is also critical for residents and fellows who may not have quite as much experience with open surgery or laparoscopic surgery. They need to understand the details of the procedure, the anatomy. These are basic things to say, but it's critical, and by observing the anatomy can be seen during robotic procedures. The anatomy can be learned. Video review and live case observation are really important, especially if you have a preceptor you're going to be working with to learn that preceptor's technique, I think. Patient selection is very important. This is generally done by the senior staff or mentor for the residents and fellows, but the residents and fellows should be asked to start training on the simpler cases, I think, as they move forward. Consistent proctor, I think, is useful too. This may apply more to somebody who's beginning their training outside of a residency program, because generally with a residency program there are just one or two surgeons who are doing the procedure, but to have a consistent proctor, to learn and practice the proctor's technique are important. The role of teleproctoring or telementoring using the Da Vinci technique is something that we've explored just a little bit. Alex touched on it some. There may be a role for this going forward, especially if you have a proctor with whom you've worked who can drop in on your case and watch it and give some advice. And I think recording the cases and reviewing them are really important, especially for the residents and fellows as they're trying to perfect the technique, to have examples of their technique for certain steps of the operation and to compare it to the expert is a useful thing. Monitoring of outcomes is really important as well. We have a database for all the different procedures we do, and we encourage the residents to go back, look at their outcomes in terms of time of procedure for the prostatectomies. Surgical margin, continence, PSA recurrence, and potency are some of the primary outcomes. And I think that for other procedures there'll be other outcomes that can be looked at, but to have some way to kind of monitor and evaluate the progress as you proceed through the learning curve. It's important to have an adequate number of patients too. So, and this is something that you need, not just one or two cases and then you have a month or so before you come back to do another case. If you're trying to learn this, the repetition is really important. That's true for the residents as well as established surgeons. I think it's important too that criteria be established for competency beforehand, and some of the points that can be emphasized are just knowledge of the equipment, how to set the robot up, and competence in use of the equipment, understanding of the procedural steps and performance of the steps, and then outcomes. In each of these you can have established beforehand. This is an evaluation tool that was published a few months back in the Journal of Urology from the group at Baylor in Houston. And this is based on a tool that's used for laparoscopic surgery. they've called it for short GEARS, which is the Global Evaluation Assessment of Robotic Skills. And it looks at several different aspects of the surgery. I can read them here quickly: the depth perception, manual dexterity, efficiency, force sensitivity, and you can see that the robotic control. And it grades it on a Likert scale, 1 to 5. And I think tools like this will become useful for evaluating the progress of residents. And if they have this, they can understand how they're being evaluated. They can look back, and I believe that things like this will help us, help our residents learn how to do the procedure better. Once privileges or once competency is developed, it needs to be maintained. This slide may be less germane for a resident or a fellow who's still in training, but a practicing physician who has developed and achieved privilege to do a surgery needs to be monitored after that has been granted, so that the competence can be reassessed, and we can make sure that the surgeon is still operating at a satisfactory level. So these are the experience that our trainees have is to start with the robotic setup, and they work with our nurses on that. They work in a pelvic trainer in a dry lab setting. We have both the Ross surgical simulator and the Mimic simulator, and we have our residents and fellows use this, and I think this is particularly useful for learning the basic movements of the robot, which really saves quite a bit of time as the trainees begin to work on patients. They'll review video of cases. We have a 3D system in our operating room, so the residents can actually see the 3D view that the surgeon gets, and that again helps with understanding of the anatomy. They then work as an assistant, and we'll have 1 or 2 assistants helping us on each case. They learn about the instrument introduction and change, suction, clip applicator, changing the lenses, just the basic robotic functioning, and they become very used to working in the laparoscopic environment. Then they begin to move onto the console, and we have used the idea that Dr. Motri talked about, of the sort of modular training, where there are some simpler steps that are done initially, and then they move to the more complex steps. And the final thing is the dual console, which we've had a little bit of experience with, and I think that this is something that will be very useful in the future for training residents to be able to jump into an operation as a surgeon who's mentoring somebody and demonstrate a technique, and then jump back out without having to displace the trainee from the console. I think will make it a much more efficient and perhaps enjoyable procedure for the trainee as well as for the mentor. I think the simulators are going to have a big role too going forward, as Dr. Guru covered. Especially this host idea is something I'm very interested in. To be able to take somebody through an operation, to be able to practice an operation, I think will really make learning the surgery a much more efficient thing. So that will end my comments. Thank you very much.